You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at Dana-Farber Cancer Institute, where I lead our small cell lung cancer program. Welcome to Medscape's In Discussion series on lung cancer. Today, I am particularly excited about a discussion focused on small cell lung cancer, and I have an exceptional guest today. I'd like to welcome Dr. Lauren Byers, a professor and physician scientist in the Department of Thoracic and Head and Neck Medical Oncology at MD Anderson Cancer Center in Houston, Texas, where her research focuses on studying the biology and novel therapeutic approaches for small cell lung cancer. Dr. Byers, welcome to In Discussion.
Thank you so much. It's really great to be with you, Jacob.
So I'm excited to talk with you about small cell lung cancer, but before we get to that, just what has your career path been, or maybe your life path that has led to this point in your career? What made you get into medicine, get into medical oncology, and then really start focusing particularly on small cell lung cancer?
I was really fortunate. When I was a medical student, I was accepted into a Howard Hughes fellowship program at the National Cancer Institute. And I got to spend a year there working in a lab that was using new technologies to see which genes were turned on in certain lymphomas. And as part of that team, we figured out that even though lymphoma could look the same under the microscope between two patients' cancers, that they could have very different genes that were turned on. And that was a major driver of which patients were responding to the current treatments at that time. And so that really got me excited about the idea of personalized medicine and, how a lot of these new technologies to look at the molecular aspects of cancer could potentially change how we took care of patients. So that really was a big driver for me. That was the year the first human genome was published and the first targeted therapy was presented at the AACR oncology meeting. So again, I think just a lot of excitement about where the field could go. And then when I came to MD Anderson as a medical oncology fellow, had the opportunity to bring some of those interests into the lung cancer group, where my mentor, Dr. John Haymack, and many other colleagues and mentors there were starting to take a similar approach in lung cancer, trying to understand, what are the different types of lung cancer and how can we learn more, about its biology to really drive what we were doing in the clinic.
Well, I love that this started with an interest in personalized medicine, because that has not been really the way that things have been for small cell lung cancer. And you're really kind of leading the charge, but we'll get to that. First things first. Let's start with first-line therapy. In the last few years, we've seen immunotherapy become a part of first-line therapy, the standard of care, chemo plus immunotherapy, namely atezolizumab or durvalumab with chemotherapy, both of which did not show tremendous differences in median progression-free overall survival, but was statistically significant, met its primary, particularly in overall survival. But that being said, has become a celebrated addition to first-line standard of care. So I'm asking kind of a broad question. One, can you speak a bit about the incorporation of immunotherapy and what makes it so special that this has been celebrated despite not such a big difference in median progression-free and overall survival?
I think the fact that for decades, really, there had been no other new frontline treatments that had demonstrated benefit beyond what we had been doing for more than 30 years in terms of our standard chemotherapy, that this really was a step forward. So I completely agree with you that going from a median overall survival from 10 months to 12 months is incremental, but it's a step forward. And so I think that was something that was really exciting. The other thing, there was new data that was recently presented from the Keynote trial that had added pembrolizumab to the platinum etoposide chemotherapy for the same, the extensive stage patient population. And there was some recently updated data that was presented at World Lung showing that those patients in that trial who completed 2 years of immunotherapy and, were responding and alive 2 years after starting that treatment have had really durable responses, even though the immunotherapy was stopped after the 2-year period. And so I think, again, these all point to the idea that there is a subgroup of patients who are benefiting from the addition of immunotherapy. But I think one of the really important questions is, how do we identify who those patients are? And as importantly, how do we find more effective, more innovative ways to get more patients really having durable responses to treatment?
Yeah, I totally agree. So what you're highlighting is that tail of the curve where not only maybe this didn't benefit a huge number of patients, which is why we don't see such a big change in the medians. But those who benefited, really, it's been a home run for some people. I have a patient that was on that Pembro study, first line. It was 2 years of Pembro and then stopped, actually, and then has been years out. And we unblinded her because she ended up having a small nodule, which ended up being a new non-small cell lung cancer. So unblinded her. She was treated with Pembro and is years out without any evidence of disease progression at this time. So it's these home runs that we see. So let me ask you maybe a tougher question, because the drug hasn't been around for a decade yet. But do you think that there are potentially some patients that are actually cured of their incurable small cell lung cancer? Are some of these really durable responses? Do you think that any of them may actually not have progression again? What do you expect going forward?
Yeah, I think, we've seen a signal of that in non-small cell lung cancer and certainly in other cancers. And I do think that that is going to be the case for a small number of patients with small cell lung cancer. And I think especially the recent data from those patients, like the one that you were describing, who received pembrolizumab, and then several of those patients have been off of immunotherapy for a couple of years now and still having a complete control of their cancer. I think that points to the fact that there may be some of these potentially cures. I'm always, cautious about using that term, but I think that hopefully is the case. And again, hopefully we can find ways to get more patients who are really having those durable remissions and eventually eradicating the cancer.
Yeah, and to be clear, I am not at all saying that that's what's been demonstrated, but that if we have people that in the next 10 years, they don't end up with progression, would we then consider that? And the fact that that is considered even a possibility is just overwhelmingly exciting. Let's go into the second line. We've now seen fairly recent-ish approval of lurbinectedin as a second-line therapy. This was based on a 105-patient single-arm basket trial that led to FDA approval. Of course, there are other ongoing studies with lurbinectedin. Can you just give an overview of what's your impression of the data, and has this factored into your clinical practice?
So it's definitely nice having a new option in the relapse setting. We need as many different opportunities as we can for our patients. Lurbinectedin, I think for some patients, can be somewhat easier to tolerate in terms of the side effect profile, and had an encouraging signal of activity in the trials that have been done. I do think that for many of my patients, it still can be similar to chemotherapy in a lot of ways in terms of the effect on the blood counts, thrombocytopenia, and especially with fatigue. And so as with many drugs, it seems to be different between patients, where some patients it's a great option for them, and other patients where we need to keep looking for things that have a better side effect profile for those other patients.
Yeah, I think that's fair. I mean, it is a cytotoxic. And so certainly the cytopenias were reported. Neutropenia was actually quite high, around 46-ish%, I think, in grade 3-4. But the study did not allow for prophylactic G-CSF. Now, you mentioned thrombocytopenia, which of course the prophylactic G-CSF would not help for, but is that something that you are using when treating with lurbinectedin, or with platinum-based therapy for that matter? Or what are you using as far as prophylaxis or monitoring? What's your thoughts on that?
I don't routinely do it in everyone, so it's more patient-specific. Especially if patients, for example, in newly diagnosed patients, if they've had post-obstructive pneumonias or other things that seem to make them at higher risk, then I'm definitely more proactive about using that. And for patients with lurbinectedin, some of it is looking at kind of how recently have they received other cytotoxic therapy, and have they had challenges in terms of maintaining their counts or infections or other things that point to them being a higher risk patient.
Well, since we've kind of forayed into this prophylaxis discussion, and it started with your mention of thrombocytopenia, Is trilaciclib something that you utilize? This was approved for platinum-based therapy and topotecan in particular, but what are your thoughts on the trilaciclib data, and has that factored into your clinical management of patients in your clinic?
Yeah, so it's a new approach that's approved to prevent some of the cytopenias. We now have it on our formulary. I think, again, we're not necessarily using it across the board, but I think for those patients who, because of their clinical history, seem like they would be high risk, especially, I think about patients who are maybe more frail, recent infections, or potentially high risk for developing infection. I think those are patients we're using a preventative approach as opposed to growth factors and boosting the counts sort of after they've been affected. I think that the trilaciclib can be a useful tool towards that.
Yeah, I agree. I don't tend to use it for everybody either, but particularly in patients where there have been issues with prolonged thrombocytopenia or I'm concerned about anemia. In these individuals, I have used it, and so far that's worked quite well. Generally, if I'm just concerned about neutropenia in particular, I tend to use G-CSF and Neulasta more in treating or preventing prolonged low counts. But now transitioning to some of the other treatments. So other second-line therapy, of course, topotecan has been the long-standing one. One question is, I find that people tend to use a lot of topotecan or no topotecan, it seems. Some individuals, me included, tend to use irinotecan rather than topotecan. Aside from lurbinectedin, what do you think as far as second line? Are you a topotecan user? Do you prefer irinotecan? What are your thoughts?
Yeah, I think it's so interesting because we all use essentially the same approach in the frontline setting. And then I feel like almost everybody uses a different approach in the second line setting, even within our group of thoracic medical oncologists. If you ask each person, they probably give you a slightly different answer. I do not use topotecan much at all. It's pretty rare that I use it. I'm always looking for potential clinical trial options, as I'm sure you are also, but I tend to use a lot of temozolomide as a single agent. That's something that we had a lot of experience with from some of the early trials we ran that was looking at temozolomide in combination with PARP inhibitors. But what I found is that some patients have had really remarkable benefit, including some patients really prolonged benefit, and it tends to be very well tolerated. It's an oral agent. So that's something that I use quite a bit, probably more than some other people do.
Yeah, I find that to be particularly good in patients who have CNS disease, especially if they've previously had radiation so with temozolomide, obviously get very good CNS penetration. And so that's where I will preferentially utilize that. So we've seen two different dosings of this. There was the standard 75 milligrams per meter squared per day 1 to 21 of a 28-day cycle. And then there's the 200 milligram per meter squared day 1 to 5 that was more recent, obviously not as big in numbers, although I believe the authors from that suggested that this could now be a new way of dosing this. Do you have a preference on the dosing? What are your thoughts around the dosing of those?
I usually use the 200 milligrams per meter squared on days 1 through 5. And we usually give patients antiemetics to take on the days that they're taking the temozolomide because it seems to be generally well tolerated, except for some nausea, but is well managed with that. In patients where I'm more concerned about their blood counts, I'll sometimes start at 150 milligrams per meter squared. But that's the regimen that we've used. And I agree completely with you. I think for patients, especially who have had maybe previous whole brain radiation and have a relapse in the CNS, that's something that can be quite a great tool because it gets really good CNS activity as well as outside of the CNS.
Now, you mentioned PARP inhibitors. Of course, there have been the combinations, as you mentioned, of temozolomide plus PARP inhibitor. Is that something you've continued to utilize, or was that just in trials?
I have used it just in the clinical trials, although I know some people have used it in standard practice as one tool that they go to. I do think it's been exciting to see the data that's come out from Dr. Goldman and colleagues in terms of their recent trial, which showed a pretty high response rate in patients with relapsed small cell lung cancer, so around 40% with the combination of temozolomide and talazoparib. And so this is now, I think the third trial or so in the relapsed setting to demonstrate a fairly high response rate to a combination with a PARP inhibitor. So I think it's something that we probably as a field need to think about, whether we should be leveraging that combination more. Although I think there are biomarkers that may help us identify who is potentially going to get the most benefit from PARP inhibitor-based combinations. And I think ultimately we need things that engage the immune response more effectively. So I think it'll continue to evolve.
Yeah, I have a patient who was on Dr. Farragut's olaparib temozolomide study for years, just impressive years of ongoing control. And so that combination has really been compelling, and we saw good response rates. That being said, PARP inhibitors have been a tough one. It's like there's this hint of efficacy, although not really demonstrated enough for it to become part of the established approved standard of care. Now, we've seen data with Schlafen-11 as well, and of course, you've done a lot of this work, but what are your thoughts around PARP inhibitors and Schlafen-11, and maybe that even transitions us towards some of the subtyping as well?
Yeah, so we have a clinical trial that was the first to use Schlafen-11, which is a biomarker, but it's a gene that basically causes cells that have DNA damage to die. So it predicts in preclinical studies and in retrospective studies of clinical trials, the patients who seem to get relatively greater benefit from PARP inhibitors and potentially other drugs that work by damaging DNA, such as cisplatin or carboplatin chemotherapy. I'm really excited about this trial that we've been running through the SWOG cooperative group because it's the first one to select patients for PARP inhibition as part of their maintenance treatment following frontline chemoimmunotherapy based on being Schlafen positive. And that study is getting close to completing accrual. And hopefully in the coming year, we'll have some data about how that group of patients did and whether the biomarker selected approach may be helpful for enriching that. That being said, I think that, we're also really excited about the new small cell lung cancer subtypes that we've been doing a lot of work around. And I think just like with non-small cell lung cancer, we're going to keep seeing the biomarkers and the different sort of subgroups of small cell lung cancer continue to grow and evolve as we learn more about how to move that forward.
Well, the subtyping, I think, is some of the more exciting potential foundation upon which the future of small cell lung cancer is potentially going to be built. Now, I realize there's Charlie Rudin's proposed subtypes, and then, of course, yours and Dr. Gay's proposed subtypes, both of which are very similar and set a similar foundation upon which to look at small cell lung cancer. Maybe before I dive into some of the questions around that, can you just outline what are the subtypes of small cell lung cancer?
Absolutely. For many years, and this really goes back to early work by leaders in the field, Dr. John Minna and Adi Gazdar, who recognized that there were these different small cell lung cancers. They look different under the microscope and seem to have some different behaviors biologically. And I think as research in small cell lung cancer has continued and progressed, there was really a signal that there were certain subtypes of small cell lung cancer, many of which could be defined based on transcription factor genes that were turned on. So for example, 3 of the major ones that had been identified were small cell lung cancers that expressed high levels of genes called either ASCL1, NeuroD1, or PAL2F3. But there were still other small cell lung cancers that didn't really fall into those 3 transcription factor groups. And so we had taken an unbiased computational approach to try to ask, how many major groups are there across some big patient groups of small cell lung cancer? And that really led us to a new 4th group that instead of being defined by a specific transcription factor was characterized by having really high expression of immune checkpoint genes and other signatures or markers of inflammation. And so we called that the inflamed subgroup. The current framework now is around sort of these 3 transcription factor subtypes, and then this 4th inflamed group that has come out more recently.
And essentially the premise being that different treatments may be more effective for different subtypes. So much like non-small cell lung cancer, we subtype into adenocarcinoma and squamous as well as others. And that has treatment implications for us. And what you've proposed is that for small cell lung cancer, by doing these subtypings, we actually may be better able to specify which treatment is going to be more effective for that individual. Can you speak a little bit to that point? Do we see shifting in some of these subtypes to where maybe it helps with treatment decisions or it needs to be reevaluated at a later point? Can you kind of address all of those?
I'll do my best. So I will say the big headline from the subtypes is when we went back and had a chance to look at how patients did in the 2 randomized phase 3 trials that we were talking about earlier, the Empower 133 trial and the Caspian trial, where immune checkpoint blockade was added. What we have found was that those patients who were in the inflamed subtype were the patients that seemed to get relatively more benefit from the addition of the immunotherapy. So in the case, for example, of those patients who are on the Empower 133 trial with the addition of atezolizumab, the patients who were in that inflamed group and who received immunotherapy, their survival doubled. Median survival doubled for those patients who, with the addition of the immunotherapy. And again, we saw very similar results with the Caspian trial with enhanced benefit from immunotherapy in patients who had the inflamed subtype. So I think where we are right now is at a place where, we've been able to identify this group that seems to be getting more durable responses that are kind of making up the tail of the curve. But what we need to do next is figure out, how can we find ways to enhance immune response for patients in the other molecular subtypes as well. So I think that's really where we're going. And in terms of how to do that, I think there are 2 kind of big picture ways we can do that. One is we're already developing tests and biomarkers that can be done on patients' tumors, similar to what we do with non-small cell lung cancer patients when we need to look for mutations or PD-L1. But also for patients with small cell lung cancer, the blood-based assays are going to be a real opportunity where we can do biomarker testing ultimately from the blood, from circulating tumor DNA and other approaches that'll let us be able to look not just at the time of their diagnosis, but to your point, Jacob, longitudinally at progression, how has their cancer potentially changed to escape the prior treatment, and how can we use the information about what's going on at that moment with the cancer to then decide what's going to be the best next treatment option to match them with.
Yeah, those are such important points. I mean, the immunotherapy has really led to such a huge success, but for unfortunately just a fraction of the individuals that are getting small cell lung cancer. And it is so fun to have somebody in clinic who is at the point now with what I like to call high 5 visits. They've been treated for years. They come in, their scans look great. And so it's just so fun to see people really getting back to their lives in a lot of ways. But the majority of individuals with small cell lung cancer are having progression, and we really need better treatment options. And Dr. Byers, you are leading the way in really setting the foundation for that evaluation. And with that, I want to thank our listeners for tuning in. And Dr. Byers, thank you so much for joining me. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.